Hello friends. Today we are going to discuss about cognitive behavioral therapy for panic disorder. I am Dr. Suresh Badanmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about cognitive behavioral therapy for panic disorder. And this video is meant for doctors, nurses, social workers, allied healthcare professionals, and psychologists. So let's discuss about CBT for panic disorder. Cognitive behavioral therapy was founded by Dr. Aaron T. Beck. He was a psychiatrist and is considered to be the father of cognitive behavioral therapy. Now let's understand about panic disorder. Panic disorder is defined as a sudden, unexpected, unexplained, recurrent paroxysmal bursts of panic attacks lasting 10 to 20 minutes, accompanied by several physical symptoms and anticipatory anxiety. So this definition is very clear. Sudden, unexpected, unexplained, recurrent paroxysmal bursts of panic attacks, my dear friends. So without any trigger, the patient will have severe panic attacks. So what are those symptoms they will have? One is physical symptoms, or else distressing bodily symptoms such as pounding heart, racing heart, or you can call it as palpitation, increased heartbeats, lightheadedness, fainting, numbness feeling, butterflies in stomach, increased frequency of micturition, shortness of breath, choking sensation, shaking of the whole body, tremors of the hand, tremors of the legs, hot and cold flushes, tingling sensation in the hands, legs, numbness in the legs, tightness in the chest, nausea and weakness of the whole body. So these are all the physical symptoms. What about cognitive symptoms? Invariably, the patient starts believing he's having an imminent heart attack. You will feel that he's going to choke and die now. Impending doom of death. He's going to die in few minutes. Catastrophic feeling that he's going to be paralyzed by a terror of anxiety. Something terrible may happen. Many a time patient starts believing they are losing control. They feel that they are going crazy. Many a time the patient may also say, I am feeling dizzy, I will faint, I will fall down. And many a time the patient may also say they are being in a great danger and no help will be available. So these are the thinking the patients with panic disorder will develop when they have panic attacks, my dear friends. Now let's differentiate between panic attacks and panic disorder. In panic attack, invariably you can see the time and the anxiety level invariably based upon various daily activities, the anxiety will be fluctuating. But in sudden trigger, there will be a big panic attack and it will come down. But the trigger has to be there. The red arrow clearly says there is a trigger and hence the panic attack has occurred. That means the trigger means, imagine if you are going on a road, suddenly a vehicle comes and is about to hit you. But fortunately, the driver was able to apply brakes and it stopped. And you will have a sudden panic attack. So that is the trigger is the possibility of having an accident. Whereas in panic disorder, there is no trigger at all, my dear friends. The time is there, anxiety levels, and you can see the patient will have recurrent panic attacks without any trigger, and invariably in between the attacks the patient will have anticipatory anxiety. Anticipatory anxiety means when I'm going to develop the second attack, what will happen if I develop a second attack? So that is anticipatory anxiety, and in between there will be panic attacks. And but here in panic disorder, there will be no triggers, my dear friends. There is no any precipitating factor. So at the end of each panic attacks, the patient will be shaken, exhausted, emotionally drained, and he will be anticipating for the next attack. And he will start searching what are the triggers. I'm having these panic attacks, he will stop avoiding, or he will avoid such an certain situation where he will develop panic attacks. Invariably, they'll be disabling, and many a time the patient starts using drugs, alcohol, substance use to get rid of this anxiety symptoms. And if you look at the panic disorder, the patient develops panic attacks, and over a period of time, the person starts avoiding certain situation where he gets panic attacks. Along with this anticipatory anxiety which is there, and he avoids all situation which may induce panic attacks. Hence, it is invariably called as panic disorder with or without agoraphobia. Panic disorder is he is having, without any trigger, he is having panic attacks, multiple. And the patient now starts having his own hypothesis. If I go in a crowded place, I will have panic attacks. If I travel in a bus, I will have panic attacks. If I go in a theater, which is completely filled with people, I may develop panic attacks. So he will avoid those situations. Then it is called as panic disorder with agoraphobia, my dear friends. What are the reasons for this maintenance of panic disorder? Here you can see the thoughts, emotions, behavior, and physical sensations are all interconnected. Invariably, the patients, when he has panic attacks, he believes, I am going to have an heart attack. I'm going to die now. So the emotions are severe anxiety, fear, impending doom of death. Behavior, he will avoid certain situation, or else he will ask for reassurance. He will go and stay near with his family members. Physical symptoms or psychological symptoms which will be there. And these avoidance and safety behavior will maintain the panic attacks. So, invariably, the reason for maintenance is avoidance of anxiety symptoms, and he will try to make sure he doesn't get panic attacks. Either moving away from the anxiety provoking situations, or else he will avoid all those which triggers panic attacks. Safety behaviors also will be there, carrying tablets, going only with the family members, talking over the mobile phone when he feels that he is unsafe, carrying water bottles, standing near the exit, opening all windows and doors, asking for reassurance, doctor shopping. So for these are the safety behaviors. So though avoidance and safety behaviors maintains panic disorder, although safety behaviors allow the people to enter into a threatening situation, but in long run, it is very counterproductive and the panic disorder will become chronic. Now let's enter into the CBT for panic disorder. CBT for panic disorder is a structured 16 to 20 session, each session lasting for 30 to 45 minutes, and one session per week initially, and later it can be spaced monthly one session. It can be done on outpatient basis, inpatient basis. It can be done in person or on tele psychotherapy can be done. CBT can be a standalone treatment or in combination with the medication. So, invariably, CBT is a training program in India. That means patient will undergo the training for 45 minutes to 1 hour along with the therapist for training in CBT, and remaining 23 hours at home he will rehearse. That means patient is not a passive recipient. He is an active collaborator with the therapist. That means the therapist will do therapy around 1 hour, approximately 1 hour per week. Remaining time, that is 6 days, 23 hours, he needs to go back home and practice what he has learned. Hence, it is called as training for 1 hour, implementation in the remaining time. CBT can be in combination with other psychotherapy. It can be family therapy, relaxation, JPMR, yoga, sleep hygiene, and various other combination can be used. Invariably, across the world, it cannot be a purer form of CBT. Invariably, the therapies are eclectic therapy. The combination of various thought process will be tailored according to the needs of the patient. Now let's look at the steps of CBT. There are 12 steps for panic disorder CBT, starting with intake session. Intake session is the structured assessment either done by the therapist or by his assistant. In this, the goal is to do a brief assessment, engaging the patient, and collaboratively planning for therapy. The main purpose here is to understand the patient's current problem, what are the treatment goals, providing basic orientation to the CBT. In the first session here, you will ask briefly about the problem, discuss about the expectation from the therapy, role of the therapist, role of the client, and you need to express clearly telling that it's a training program in which he will undergo 1 hour and remaining he needs to rehearse and practice at home. Many a time in India, we do take family member as a co-therapist so that they can monitor at home. Sessions, frequency, duration, and consent for therapy is done. Contact details, payment, brief introduction to CBT model and how the CBT works, session notes and documentation, and unable to come for therapy, what to be done. So these are done in the first session. Moving to the second, detailed and baseline assessments. Baseline assessment invariably starts with a detailed psychiatric assessment, collect all collateral information possible, chief complaints, history of presenting illness, onset, duration, course. Explore about 3 P's, that is predisposing factor, precipitating factor, and perpetuating factor. Family history, past history, personal history, and pre-mode personality need to be explored. Panic disorder exploration is very essential, along with you need to look for comorbidity. Invariably, 2/3 of the patient with panic disorder will have one or the other comorbidity. List all the triggers for the panic disorder, list all the avoidance and safety behaviors. What is the impact of biological, social, and occupational functioning because of panic disorder? Sometimes, if you are doing research, you may use severity rating scale and various investigation if required. Diagnosis, look for the motivation for therapy and whether he has insight for his symptoms and cognitive ability to do therapy. Now moving to the goal setting. In any psychotherapy, goal setting is very essential. Goal for the life, what he wants to become in life. Goals in therapy. What is the long-term goal in the therapy? Short-term goal in the therapy. And invariably, when you ask about goal, it should not be general. It should be very specific, which is flexible, collaborative, and measurable and actionable. That is SMART goal should be there. The goal should be very specific, measurable, attainable, relevant, and time based. For example, if the patient says he has come for psychotherapy to get rid of CBT, that is the long term goal. The short term goal will be you need to engage in CBT. You need to come regularly for therapy. You will do homework assignments. You will be able to do certain exposure behavior. So they are specific, they are measurable, they are attainable, relevant, and time based. So that becomes short term goal, my dear friends. Educate about panic disorder, why the panic disorder comes, what are the reasons, what are the triggers, those need to be discussed. Here, you need to develop at least a link between the cognitions, affective, behavior, and physical symptoms. Once the patient is able to understand there is a connection between cognitions, behavior, emotions, and physical symptoms, the CBT becomes easy. Look for maintaining factors, avoidance, and safety behavior. Explain about this to the patient. And finally, the treatment, psychotherapy alone or combination of medication and psychotherapy to be considered. Moving to the fourth step, understanding the relationship between cognition, emotions, behavior, and physical sensation. As I mentioned earlier, the patient need to understand there is a relationship between The cognition, if he has good thoughts, mood will be good, and his behavior will be good, and physical symptoms will be very minimal. If he has negative thoughts or a depressive cognition, he will have depressed mood, he will have depressed kind of behavior, dull, withdrawn, and physical symptoms will be fatigue, heaviness. So that connection has to be established. So, what happens in panic disorder? Look at the cognitions. I am going to have an heart attack. I am going to die in few minutes. I am losing control. I am going crazy. Something bad will happen now. I am having an asthma attack. I may die. I will faint. I will fall down. These are the cognitions the panic disorder patient will have. Because of these cognition, the patient will become anxious, nervous, fearful, feeling of dread, impending doom of death, choking sensation, anxiety and depression can be there. Physical symptoms: palpitation, blushing, trembling, dry mouth, dizziness, nausea, breathing difficulty. Behavior: avoidance, safety behavior, fidgety, restlessness, reassurance. Many a time they start using drugs, alcohol, and tobacco. Moving to the fifth, once he is able to understand the relationship between cognition, affect, behavior, and symptoms, the patient will start charting the panic diary, also called as journaling. Here, it is a 6-column diary in which first one is when and where the panic attacks occurred. What were the physical symptoms? Second column. Third, what were the thoughts? How severe was the anxiety? How long it lasted? And is there any safety behaviors he used? So this is 6-column chart. From the day one he starts coming for CBT, you will ask the patient to maintain this panic diary. For example, he will chart like this. At 10:30 a.m. in the marketplace, I had severe panic attack. Numbness of the body, numbness of the extremities, tremor, choking sensation, palpitation. Thoughts: I am having an heart attack. And the rate of anxiety was -10, very severe. It lasted for 20 minutes. What was the safety behavior? He ran to the hospital, or else he went to the emergency consultation. In a casualty, ECG was done, echo was done. So, this is how the panic diary is charted. Moving to the sixth, behavioral exposure. Before the behavioral exposure is done, the patient needs to understand the principles of exposure, that is, habituation, extinction, emotional processing, and self efficacy. What is habituation? Here, the patient should understand the rationale why the exposure is done. Repeated exposure or repeated stimuli decreases the response over a period of time. That is, he needs to understand by exposing himself, the emotions towards a thought start fading out. And he needs to understand the role of safety behavior and avoidance in the long run. By removing safety behavior and avoidance, he is going to expose himself. The anxiety will increase and he needs to tolerate that anxiety. Once the habituation of the anxiety occurs, he gets the cure from panic disorder. You need to explain the habituation and extinction by using diagrams such as this one. You can see time and anxiety. As soon there is an exposure, the patient will not be able to tolerate the panic peak. He will have avoidance. There is a temporary relief, but again, there is no habituation. And whenever there is an anxiety, it continues without any relief, my dear friends. The relief will be very temporary, but it will be permanent. Suppose if the avoidance is removed, the patient exposes himself, does not use any kind of safety behaviors. In such a scenario, my dear friend, the exposure will be long. The anxiety symptoms will continue for maybe 1 to 2 hours, and slowly the patient will get habituated with the anxiety symptoms. as you see here. And once the habituation occurs, then anxiety comes down on its own. If the exposure occurs at the first time, the anxiety will be very high. Second exposure, it decreases. Third exposure, fourth, fifth, and subsequent exposure, the anxiety does not mean anything to him and he will be getting used to these anxiety symptoms. So, how to do exposure? Introspective exposure is the one which is done. Here, one of the most powerful underlying cause of chronic panic disorder is the patient believes these physical symptoms are going to kill him and they are severe and they are life threatening. So he needs to understand and expose himself and test his hypothesis. These physical symptoms that what he fears are not death leading physical symptoms. Hence, this is called as introspective conditioning. Here, whenever the patient has panic attacks, palpitation, and choking, he will believe that he is having an heart attack and he is going to die. That is misinterpretation of the physical symptoms. Because of this, anxiety further increases. Imagine if you're going to die, what will happen? You'll have severe anxiety. And this anxiety further adds to the already ongoing panic attacks. In such a scenario, the patient will do avoiding certain actions, situations where the panic will occur, or he develops a safety behavior like taking tablets or else asking the family member to reassure. Now, in introspective exposure, we need to stop this avoidance and safety behavior. By doing this, the patient will have a continuous exposure to the anxiety symptoms. And you need to remove the misinterpretation, telling that you are having anxiety symptoms for 1 to 2 hours or 3 hours and you did not had any heart attack. By undergoing this exposure for a period of 2 to 3 weeks or 4 weeks, he will get rid of panic disorder. So that is how introspective exposure is done. Here, therapist assisted exposure can be done during the session, asking the patient to run in the therapy room in a standing in the place, and he will run there like a jogging, maybe 5 minutes, 10 minutes, till the panic attacks occur. Walking up the stairs, ask the patient to climb 3 to 4 stairs, case he will immediately will have panic attacks. Hyperventilation, to simulate the shortness of breath. Spinning, asking the patient to spin, so that dizziness, increased heart rate, palpitation mimics panic disorder. Now you need to ask to analyze before the introduction of panic attack, what was he thinking, what was anxiety symptoms, and what was his behavior. Analyze and ask him during the panic attacks, what did he think, what was his behavior. Finally, after the panic attacks, what does he think? So you need to challenge these panic like symptoms and the catastrophic interpretation of the patient. These anxiety symptoms are common to everyone. In panic disorder, that catastrophic interpretation of those anxiety symptoms induce panic disorder, my dear friends. Hence, the role of exposure is identify those sensations before the panic attack occurs. By recognizing and name the physical symptom. Yes, this is my increased heart rate. Yes, I am having palpitation. And suddenly the mind will start telling you are going to have an heart attack. Now you challenge that catastrophic interpretation. No, I am not having heart attack. It is a false alarm. It is an anxiety symptoms which occurs with everyone, and I am having anxiety symptoms. Accept and reframe the interpretation. Yes, I am also a human being. I am also having anxiety symptoms, and it is harmless. And reframe the experience. Within another 30 minutes, it will go off. Wait and observe the anxiety symptoms. By doing this multiple times, the patient develops habituation. Many a time, you need to do step by step graded exposure for avoidance. Many a time patient will avoid many certain things that needs to be exposed. Hence, the patient needs to draft a theory of hierarchy to confront the triggers progressively, reducing avoidance through habituation. The patient need to make list of 10 to 15 items where he avoids or uses safety behavior from mild to moderate to severe. That is, mild anxiety provoking to severe anxiety provoking situation needs to be listed. For example, I have listed here the way the patient has mentioned here in a panic disorder with agoraphobia, moving away from home alone is 20% anxiety. Being in open space, 30%. Standing in a line or being in a crowd, 40%. Being in an enclosed space such as lift, 50%. Locking himself in a washroom or a toilet, 60%. Using public transportation, 70%. Traveling on bridge, 80%. Dizziness and falling down, 90%. Once he is able to make the hierarchy, now we will focus on the first simple, least anxiety provoking symptom need to be chosen. And you need to find the triggers for this. What are the triggers? For the first one is standing near the door alone. First, for 5 minutes and see how he does. Do this 6 to 7 times over a period of next 1 week. After 1 week, if the patient is able to tolerate the anxiety, ask him to stand outside the door alone for 5 minutes, 5 to 6 times in a day for next 1 week. After that, going and standing near the gate of his house, 5 minutes, and it will be 5 to 6 times in the third week. Standing 10 meters away from the home, moving 20 meters, 30 meters, 40 meters. So he will move further away from the home and he will tolerate the anxiety without using any avoidance or safety behavior. Further, standing outside a crowded shop, standing near the gate of the crowded shop, going inside and buying something from the shop. By doing this, he will get habituation, but you have to make sure there is no avoidance and safety behaviors, my dear friends. Now he will rate the panic diary now. Suppose if the patient is been exposing, he is going to a marketplace where he has panic attacks and is able to believe that initially this I'm having a heart attack, but he will clearly say himself that this is a false alarm. Although anxiety may be up to -10, the whole anxiety lasted for 20 minutes and he will sit in the marketplace till the anxiety goes. That means it is habituation occurs. So this is how the exposure is done, my dear friends. In the exposure task, do not delete the task. Go on adding the task. Once the patient get mastery over each task, he needs to continues to do daily so that he gets mastery. So don't delete any task. Add anxiety reducing medication or relaxation if required only. Although many researchers believe adding anxiety reducing techniques, either medication or JPMR or relaxation, will come in the way of habituation. Hence, many a time, many of the behavioral therapists avoid suggesting for JPMR. But however, if the patient has severe anxiety, he does not do any exposure in such a scenario, either you have to give medications or anxiolytics, or else you need to do JPMR so that the patient is able to tolerate the anxiety. He should learn about breathing techniques, yoga, and also, if required, JPMR. But however, the need for JPMR or anxiety reducing techniques need to be collaboratively decided by the patient and the therapist based upon the requirement it has to be suggested. Further, grounding techniques can be taught to the patient. Whenever the patient has severe panic disorder, he can start doing grounding technique to activate parasympathetic nervous system. Find 5 things you can see. The patient is sitting in a market and he's having severe panic attacks. He will do 5 things. He will see 5 things in his surrounding. He will start naming them: chair, fan, light, door, windows. So he will name 5 things. He will touch 4 things and name them. He will find 3 things he can hear. He will hear the sound of a car honking, somebody talking nearby, and a music played on a radio. He will start imagining 2 smell which he would like to recall. Find 1 thing he can taste. So by doing this grounding technique, he is able to tolerate the panic attacks. Moving to the 7th, identifying dysfunctional cognitions. Once he has gone through the panic diary and he has marked around 2 to 3 weeks or 4 weeks about the panic attacks, why it has happened, what are the thoughts he is getting. Now you need to list all the cognitive distortions, cognitive schemas, and automatic negative thoughts. Cognitive distortions in panic disorder is catastrophization. That is, he's going to have an heart attack and he's going to die now. All or none phenomena. If I feel dizzy, that means I'm losing control. If I lose control, means I'm going crazy. Abnormal risk assessment. I will die. If I develop choking, I'm going to die now. Overgeneralization. One attack of panic means I will be panicky always. Mind reading. He starts believing people are able to note that he is going through a panic attacks and they will judge him. That is mind reading. Should statement. I should not feel panic. I should be in control. If I have panic means I am very weak. Labeling. I am a nervous wreck. I am good for nothing. Minimizing the positivities. For example, the patient from his birth never had panic attacks, but he is having panic attacks since only 1 month. He will dismiss whatever never had a panic attack still past 1 month. Since 1 month he's having panic attacks, he will focus that I'm going to have panic attacks and I might die. So minimizing the positives but focusing on negatives. What are the cognitive schemas? Vulnerability to harm. My body is fragile. I am unreliable. I may have an attack. My heart is very fragile. Uncontrollability. I can't manage this intense anxiety, intense emotion. That means I'm very weak. Low self efficacy. I lack coping skills for anxiety. I'm good for nothing. So these are the schemas. What about the automatic negative thoughts? Situational. I'm going crazy. I'm losing control. I may not get any help. Palpitation. This means I'm fainting. I will fall down. I will die soon. Symptom focused. Something terrible will happen now. I may die also. So these are the various cognitive distortions, schemas, and automatic negative thoughts. Now you need to challenge these dysfunctional cognitions. Suppose the patient has catastrophizing cognition, or maybe call it as cognitive distortion. I'm going to die. I'm going crazy. I will lose control. I'm going to have a heart attack. Expose the patient to various panic-like situation and see after 1 hour, did he die? So challenge those catastrophizing cognitive distortions. By doing many times, the patient will be able to understand these are all false alarm. You may also challenge the patient asking, how many times these panic attacks occurred? What did ECG say? What does the echo says? What did your cardiologist say? By asking such questions, you can challenge their catastrophic interpretation that is they are having heart attack. Moving to the 9th, problem solving. Many times with the patient with anxiety disorder will have various other problems related to interpersonal problem, occupational problem, social skills problem. So the therapist should help the patient to solve their problems. Ask the patient to identify the nearest problem which he needs to solve and which is emergency. Ask the patient to chalk out all the possible solution, positive and negative of each solution, and finally choose the solution he wants to implement. Once he implements, see the result. If there is no change, move towards the next possible solution. You may also have to do social skills training, coping with fear, Please make sure the patient understand there is no avoidance or no safety behavior. Then only the habituation will occur and he will get rid of panic disorder. You need to give homework assignments, that is exposure techniques, exposure at home, that will help him to overcome panic disorder. 10th, weaning and relapse prevention. Once the patient reaches 14th or 15th session, you should discuss about the number of sessions left, and spacing the sessions has to be done. If you are doing weekly one session, now you have to do monthly one session. Explain him and also say we are here to empower him, making autonomous so that he becomes independent and is able to conquer the panic disorder. And he also has to be reassured that if he requires help, the help will be available. He needs to seek help from the family members, friends, and spouse. But it should not be reassurance seeking or it should not be safety behavior. And he needs to ask help from the family members for exposure, keeping time, challenging his thoughts. By doing this, you'll be able to overcome panic disorder, my dear friends. So, setting clear goalposts is very essential for relapse prevention. 11th, consolidating the session. Here you need to discuss about how many sessions he has undergone, what was the anxiety symptoms we came, what were his cognitive distortions when he had come, how much he has achieved. Rehearsal the key points, plan for ongoing support, if required, booster session, seeking help from other people, and reinforcing the gains what he has got. Finally, the booster session. During the booster session, it can be once in 6 months or once in 3 months. Look for any new symptoms, look for comorbidity, look for any relapses there, motivate for regular engagement in exposure, support autonomy by discussing the empowerment of the client. To conclude, my dear friends, CBT is one of the effective way of treating panic disorder. CBT is a structured way of doing psychotherapy for panic disorder. In CBT for panic disorder, you will focus and elicit cognitive distortion, cognitive schemas, and automatic negative thoughts. And you will make sure his avoidance is less, safety behaviors are not used. He does exposure by using panic diary or journaling, and he will challenge all his catastrophic thoughts and cognitive distortion. 16 to 20 sessions are required, each session lasting for 45 minutes. Initially, one session per week is done. And finally, my dear friends, once the patient is able to learn cognitive behavioral therapy for panic disorder, he will be able to implement it and get rid of panic disorder. Thank you very much for giving your valuable time. Stay safe.